Good morning, all. Thank you for joining on this Sunday morning. So today with us is Dr. P. Ajay Kumar from Hyderabad. Doctor is MD in tuberculosis and respiratory medicines. And Dr. P. Ajay Kumar has done fellowship in HIV medicines from CMC Vellore. Dr. Ajay Kumar has received Best Paper Awards for HIV and TB Radiological Spectrum in APT Con 2004. And even Doctor has received Best Paper Award for tumor markers CA and CA15-3 in malignant and tuberculosis pleural effusion in Epicon 2005. Dr. Ajay has attended many workshops on HIV and he has been a resource person in HIV/AIDS training program supported by NACO. And Doctor has worked at ART Center for almost 5 years and before starting his practice at Sai Srinivasa Hospital, Narayanguda, Hyderabad. So, doctor is today now almost from more than 12 years. Doctor is healing HIV patient at Hyderabad and is having vast interest in HIV and experience. So, today doctor will be sharing his experiences with us in the HIV management. So, doctor, now over to you, sir.
Yeah, good morning, everyone. Today I'll be discussing about two interesting cases in HIV, which we commonly, as a pulmonary practitioner, I often see chest problems in HIV. So these are the common ones that I see regularly. So I thought I'll share my experiences and about the practical points in treating such cases. So directly coming to the case study, this was a female aged 30 years. So this was just a month ago, 1 or 2 months ago, I think. So she came with shortness of breath and she didn't have any fever, but the main complaint was shortness of breath. She had dry cough and she also had other symptoms which were not significant, loss of weight and loss of appetite. But she was under treatment from some other physician and he was treating her with bronchodilators and antibiotics. She was receiving on and off treatment with bronchodilators and antibiotics on and off since past 2 months, but her breathlessness was not subsiding. So maybe they have not thought about the possibility of some other diagnosis. So later on, when she was investigated from other doctors, she came to know that she was having HIV. So she was continuing the same antibiotics when she came to me, and she brought the reports, other reports, which included HIV report. Apart from that, she also did her X-rays, liver function, and LFT. They were all normal, but her hemoglobin was very low. She was severely anemic and she was looking very weak. She had pallor, and when they also got her CD4 once she was diagnosed as HIV. She also had her CD4 count done, which was 18 at that time. So with this background, she came to me, and they were a little reluctant to get admission because of the stigma and all. So as she was in a very bad state, I mean the saturations were very low at the time of when they first saw me. I thought I thought of admitting her, but since they were not keen for admission, I was just treating her for a few days on OP basis. So when they just brought me, this was the X-ray that I have shown, and as you can see from the chest X-ray, there are clear perihilar prominence. You can see the clear butterfly type shadows in the perihilar areas on both lung fields. So when what are the things that you need to keep in mind when you see a HIV patient with a very low CD4 count and coming with breathlessness? So when you see an X-ray or with this clinical background, the first thing that comes to your mind is some lung infections, maybe fungal or viral or maybe tuberculosis. But the problem with these patients is it's very difficult to get the required sputum for diagnosing. So most of the times you may have to start them on empirical treatment when you don't have enough uh, investigations available, and especially so when the patient is not cooperative and not very reluctant to do further investigations. So thinking this background, in keeping this background in mind, I thought she had some fungal infection. And then they also got a CT, but I couldn't get the CT. They were because of the COVID problem. I couldn't get the CT properly. I had to just take a picture from WhatsApp. As you can see, there are clearly uh, in the lung window there are shadows in the both bilateral lung fields. Though the pictures are not very clear, but the X-ray was enough for me to come to the conclusion that she had PCP pneumonia. So, what are the practical points in treatment of PCP? I just wanted to share my experience. So, when do you suspect PCP in HIVs? So, when a patient has very low CD4 counts of less than 100 copies or less than 50 copies, and when the patient comes to you with symptoms of acute shortness of breath, even under the background of HIV, and when the patient has dry cough, so you suspect PCP in such cases. So these are the common symptoms that you see. And the other important history that you need to take in these patients is, was the patient on any prophylactic drug, especially Bactrim DS, because Bactrim, as you all know, gives protection against all many fungal and bacterial infections, including PCP. So obviously, this patient was since she was diagnosed very recently with HIV, she was not on any vaccine prophylaxis. So the common symptoms, she had all the typical symptoms of PCP like shortness of breath, dry cough, and she was very weak, and saturations were less than 80 at the time of consultation. So, what are the possible differential diagnosis we come across in these patients? Are we commonly many patients often have coexisting tuberculosis along with PCP, and even tuberculosis sometimes miliary pattern becomes very difficult to make out whether it is TB or PCP. And the others are the common bacterial infections like community acquired pneumonias, where it becomes very difficult because we all start regular antibiotics when we see a patient with pneumonias. So these are the possible differential diagnoses. And patients who have pulmonary edema, they also present with a classical butterfly-like pattern on X-ray, which we commonly it's very difficult to make out whether it's PCP or pulmonary edema unless you have the prior history of the patient is having any cardiac problem or any heart failure. So these are the common differential diagnoses that we think. So how do you diagnose these patients with PCP? We, to be honest, I have not done any lavage in any of the PCP patients, and never did any staining or PCR. But the most of the times, my diagnosis has been clinically based on chest X-ray and CT scan, because with the background of low CD4 and classical symptoms with clear chest X-ray, I often start the patients empirically on Bactrim tablet, that is sulfamethoxazole and trimethoprim. So the dose is around 160 milligrams of trimethoprim along with sulfamethoxazole. This is they have to take at least 5 to 6 tablets per day. So along with Bactrim, many of them will need steroids, and steroids have to be initially have to be given in high dose. Maybe later on we can taper it down, but since many of them have severe oxygen desaturation, so they need steroid and supplemental oxygen and nebulization. So this is the common approach that we follow. And the main important diagnostic problem in these patients is, when do we start ART in these patients? So when a patient is having CD4, many of them, even the patients, they start telling us to start ART early. But the problem in these patients is you cannot start both at a time. So, and the other important problem here is many patients are sensitive to Septron. So many I had a recent experience with a patient where patient was diagnosed as PCP, and I have started him on Bactrim, but because he was also having low saturation, he was also started on steroids simultaneously. So I couldn't, because he was already on both Bactrim and steroid, I couldn't make out whether he was sensitive or not. So the next day, he developed reaction to Bactrim. So this is again a big problem where many of us we start Bactrim and steroids together because of the patient's condition, but in that patient, unfortunately, the patient was very sensitive to Bactrim and he developed severe reaction. And in that patient, we had to stop Bactrim and we had to start with clindamycin and trimethoprim. So here, the main important thing is we have to make sure that the patient is not sensitive to Bactrim when the treatment is initiated. So we give half tablet or one tablet to begin with, and see for 6 hours if the patient is tolerating or not. If the patient is tolerating, maybe you can start with steroid along with these Bactrim. So the other important problem is when you start ART in these patients, they do not they are because of the cross reactions with some of the these antiretroviral drugs like efavirenz especially and nevirapine, which causes skin reactions in these problems. It becomes very difficult to make out whether the reaction is because of Bactrim or because of nevirapine. So in such cases, it's always advisable to wait for at least 1 week before you start any antiretroviral, or you can start with any antiretroviral which are not having any skin reactions. So in that patient, we started ART after 1 week. This is the ideal time because many patients, because of the huge dose of Bactrim, they do not tolerate ART in these patients. I mean, in the beginning. So we start them on Bactrim, and then after 2 weeks or 1 week, we start them on ART. So this patient was started on antiretroviral drugs after 2 weeks, and she completed 3 weeks course of Septron, and she's now on antiretroviral drugs, and she's fine now. She recovered, but we may have to. The main problem in these patients is when you start ART at a very low CD4 counts, there is every possibility of developing immune reconstitution syndrome again. So we need to watch them carefully for any relapse of PCP or any immune reconstitution. Again, we have to check the CD4 count and follow up closely. So that was about the brief uh, uh, case on my first case. Coming to the second case, uh, if there are any questions, I'll be happy to take them at the end of the lecture. So this is coming to the second case. This was a 28-year-old male. He came with symptoms of loss of appetite and loss of appetite. He had no fever. He didn't have any cough or shortness of breath. He was very young, and he was not married. And when he came to me, his CD4 was already 40, it was very less. So, and because his weight was not much, he was around 40-45 kgs. So I started him on dolutegravir based regimen uh, along with tenofovir and emtricitabine. And at the time of starting the antiretroviral drug, his X-ray was normal, his sputum was negative. So here, because he did not have any symptoms suggestive of TB, I started him on dolutegravir based regimen. So he was on treatment with this regimen. So he came to me again after 1 month of taking antiretroviral drugs. He came with breathlessness and fever and cough. He was also started on, I mean, at the time of ART, he was also kept on Bactrim as a prophylactic drug. So then after 1 month, he came with shortness of breath, fever, and cough. Like the case I have discussed earlier, here the possibility of PCP is still there, but since he was already on prophylactic Bactrim, the probability of PCP was less in this case. So I had to, because he was very breathless, I had to admit him, and he was again investigated with chest X-ray and CT scan and other routine investigations. And the CT scan showed clear classical miliary tuberculosis, which was not very clear on X-ray. So here again, they have a lot of problems. I mean, in patients who are started on ART, this is a common scenario where after starting antiretroviral drug, they come with some of the other infections. So here, because he was diagnosed as miliary tuberculosis, his ART was stopped, and the patient was started on anti-tuberculous drugs. So he was in the beginning 2 3 days he was fine, and again after taking 4 days of ATT, he came with the vomitings. So he was complaining of vomitings, and uh, on the seventh day or so, I did LFT, and he came for follow up, and he had icterus. So his LFT was high, around serum bilirubin was 4.5. So, in spite of stopping the antiretroviral drug, and he still developed jaundice. So, ATD was stopped because he was serum bilirubin was high, and he was not on any ART or any ATT. Then after a few days, I started him on. I stopped the pyrazinamide. I've started him on low dose anti-TB drugs, rifabutin and ethambutol and levofloxacin, because the plan was to continue dolutegravir, considering the fact that his weight was not more. Maybe I thought he even may not tolerate efavirenz, because many of these patients who have low weight complain of lot of dizziness and all with efavirenz. I thought of continuing dolutegravir, which is more potent and with less side effects. So with that thinking, I thought of starting. I started him on rifabutin, ethambutol, and levoflox, and he was continued for a week or so with the same regimen. And his LFT was repeated again after 1 week or 10 days or so, and his LFT was almost normal after 1 week, and the patient was restarted with modified dose of ATT anti-TB drugs. So here again, I had to stop my macro pyrazinamide, because all the anti-TB drugs are hepatotoxic, but most of it pyrazinamide and isoniazid rifampicin. So I've started him on only on rifabutin, ethambutol, and isoniazid. Along with levoflox, he was taking ATT, and ART was started after approximately around 10 days of starting ATT. ART, the same regimen, dolutegravir, tenofovir, and emtricitabine was restarted after the patient tolerated the ATT. So here, as you can see, the after keeping the patient on anti-TB drugs and ART drugs, these are the common problems that we face. Many patients do not tolerate, and they come with new problems. So the here I wanted to highlight some practical points, which practical aspects that we face. I mean, difficulties that we face in managing TB in HIV patients. So the first point is, when do you suspect patient has TB in HIV? So here again, whenever the patient is on antiretroviral drugs, and if the patient is not gaining weight, or if the patient is not gaining appetite, so here again, we always have to suspect tuberculosis. And many patients, they do not have any symptoms. So in that case also, it's very important that we need to keep TB under the background. So here the patient, because he had classical fever, cough, I thought he might be having TB. But again, many patients, they don't have any such symptoms, large symptoms, and they develop TB. Like some patients have lymph nodes and all that. So, what are the diagnostic tests that we do to diagnose TB? Again, here it's a very big challenge because most of the time the sputum test comes negative, and the chest X-rays, which are most of the pulmonary tuberculosis, we can make out TB. But again, when the patient is having extra pulmonary tuberculosis like lymph node abdominal tuberculosis or some other tuberculosis elsewhere, it becomes very difficult, and it poses a diagnostic challenge. So in such cases, we always have to keep the background of his HIV status and also the CD4 count, what are his immune status. These are all should be kept in mind. So some patients have, though some patients have chest X-ray completely normal, they still have TB. So in such cases, you may miss out on endobronchial tuberculosis, which very commonly presents as a normal chest X-ray. The only way to diagnose such cases would be by doing a bronchoscopy and a lavage. So always keep that in mind when you're treating HIV patients. And what are the difficulties that you face in diagnosing TB? The most important one is when many of the physicians, when they treat patients with HIV, many of them come with cough and fever to start with. So here the antibiotics, choosing the antibiotic is very important, because outside many practitioners, they use quinolones as a drug of choice for treating upper respiratory infections, thinking that it could be minor strep pneumonia or streptococcal infection. So they start with them on quinolones like Leoflox or Oflox. So in these patients, because tuberculosis is partially it responds to quinolones, the problem is they have a partial response to quinolones, and when they start on quinolones, they give it for 1 week or more, 1 week or so. So in such cases, what happens? The patient gets partial response to TB, and his fever comes down, cough subsides. Then the patients are started on ART. Then after starting ART, again the patient comes back with fever and cough. So the most important thing here is, do not start any quinolone when you are treating a patient with tuberculosis. I mean, when you are treating a patient with HIV, especially when you have a suspicion that because of his low CD4, he might develop tuberculosis. So in that case, it's ideal to start with an antibiotic which do not have any anti-TB activity, like for example, ampicillin with clavulanate is the best antibiotic. You start them on 1 week for 1 week or so and see the response. If the fever is still not coming down, or if the patient is not gaining, I mean, improving appetite, or if he is still developing worsening symptoms, then you can evaluate such patients with chest X-ray and other investigations, sputum, gene expert, like these investigations might give some clue that patient might be having tuberculosis in such cases. So these are some of the common diagnostic problems that we face. And when do you start ART in these patients? This is another very common problem. Like the previous case which I discussed, when you start the patient on TB, it's always advisable to wait for at least 2 weeks time. Give some time for the patient to get adjusted to these TB drugs, because many of the patients who are HIV and TB, they are very low. They have loss of weight. Their weight is not more than 40-45 kgs. So these patients are very likely to develop some of the other drug reactions to tuberculosis, especially hepatitis, which in the coming slides I'll be showing the data also. Many patients with HIV, when we start them on anti-TB drugs full dose, they develop toxicity. So, and as you know, when you start with ART, you can only give efavirenz if you are in a national program. Like they start only on efavirenz based regimen when patients is on TB. So there are some cross reactions also. So ideally, you wait for 2 weeks before starting the patient on antiretroviral drug. So again, because many of them have low CD4 counts while starting antiretroviral drugs, we often see when we start the patient on antiretroviral drugs, they come with some other problem like they develop lymph node swellings, especially in the neck or axillary area or inguinal area. Some people develop abdominal adenopathy also. And these lymph nodes can be very difficult to treat. And again, the possibility of iris TB has to be kept in mind. Because of the immune reconstitution, the latent tuberculosis they get reactivated, and we may have to start ATT again after starting ART. So here it's a difficult situation where we have to prolong the course of TB and ATT ART. Along with we may have to give him steroids also because the immune reconstitution it responds well to steroids. So we may have to give steroids for 1 or 2 months in some cases. I've seen cases of TB, especially TB iris. They have continuously they develop lymph nodes, and they whenever we try to reduce the dose of steroids, the lymph node starts popping up again and again. So in this case, in this scenario, we may have to gradually lower the dose of steroids over a period of time, and check his FNAC or biopsy to know whether the lymph node has active TB or it's just a reaction to the underlying inflammatory response. So, the coming to the role of steroids, is there any role of steroids in TB HIV? There are only two indications. One is what I have just mentioned, the immune reconstitution inflammatory syndrome TB, where you definitely have to give steroids. And the other one is the TB meningitis. Here in TB meningitis, many patients have the probability of developing iris TB and all is more if when you start the patient on ART early. So here we start the ART minimum. We wait for at least 2 to 3 weeks and sometimes even 1 month also, because the prognosis is not good when the patient is having low CD4 with TB meningitis, and the complications are more in such cases. So here again, there is a definite role of steroids in such cases. And coming to the drug interactions, these are the common. There are some common drugs which are used in TB HIV where you can have drug interactions. For the in the NACO program, initially all patients were started on zidovudine, lamivudine, or zidovudine with stavudine along with nevirapine. So in such cases, when the ART regimen is started with the nevirapine-based regimen, the most common problem that we used to face was if a patient on nevirapine-based regimen develops TB. So in such cases, you cannot give rifampicin because the rifampicin lowers the drug nevirapine levels. So in such cases, we used to change the regimen from nevirapine to efavirenz, and because of that, patient will be changed to ATT and efavirenz based regimen used to be given. The other important thing is patients who are on isoniazid. Some patients develop psychosis. It's very common. Not. I mean, chest physicians might agree, but when we see patients on when we start them on isoniazid and full dose ATT regimen, they develop some altered sensorium, difficult to know what's happening. So again here, efavirenz also has a similar problem. When we give them, when we start them on efavirenz, they have this dizziness, especially in the morning times, and there is an interaction. Sometimes when you give both isoniazid and efavirenz, the effect is even more. So in such cases, we try to stop both isoniazid and efavirenz and switch to some other drug. And again, as I mentioned earlier, efavirenz can also cause bacterium can also cause skin reaction. So does efavirenz. So sometimes bacterium causes severe Stevens-Johnson's type syndrome. I've also seen patients with efavirenz developing similar reactions. So whenever you start antiretroviral drug, please do not start bacterium and antiretroviral drug simultaneously, because You will never know whether he was sensitive to bacterium or to an ART regimen like efavirenz or nevirapine. So try to avoid. You start the patient on Bactrim first, and after 1 week or so, you can start the antiretroviral drug because antiretroviral drugs are never an emergency. So you can wait till the patient tolerates Bactrim. The other common thing that we've seen was this peripheral neuropathy. Previously, stavudine was the very common drug which was given along with nevirapine or efavirenz. Stavudine it causes a lot of side effects, one of which is peripheral neuropathy. And many patients also develop lipoatrophy and lipodystrophy, but the more important one is the peripheral neuropathy, which again, patient if is already on anti-TB drugs, especially isoniazid, they'll again have the same problem. So here, if they have any peripheral neuropathy, we usually stop stavudine and also isoniazid sometimes, and he may have to take a lot of supplements for that. And the other drug common interactions now that is common on the problem now is because many patients are now being put on dolutegravir based regimen, and if they develop tuberculosis, again there is a problem with rifampicin. And here again, if you want to continue the dolutegravir, you can double the dose of dolutegravir. So instead of 300, you can give 600 mg along with rifampicin, or you can shift to a rifabutin based regimen along with dolutegravir. And the last one is the common patients on atazanavir. Again, all as you all know, rifampicin decreases the levels of all PI protease inhibitors. So you cannot give atazanavir or lopinavir or darunavir for that matter. You cannot give any PI inhibitors along with rifampicin. So it can be given with rifabutin in such cases. So, as the slide shows, the tuberculosis in our country is the most common opportunistic infections, and there is also I have seen a lot of cases of PCP also in such patients who have advanced HIV. So this again shows the different infections that we encounter in HIV patients. So there was a study which we have done in the when I was doing my post graduation. So we this is pertinent in this case because we here studied the what are the radiological manifestations? How was the clinical and radiological manifestations of tuberculosis in HIV patients? This was the main objective of the study. So we have analyzed retrospectively around 351 patients of tuberculosis with HIV. When I was working in at AP Chest Hospital, it's almost in 2001 and 2003. So here the diagnosis of HIV was done by regular TRIDOT, and diagnosis of tuberculosis was done by routine investigation, sputum X-ray, and FNAC. So I would be only highlighting the important radiological aspects that you need to keep in mind when treating tuberculosis. Here, the age, these are the different age groups that we have seen. Most of them were in the 20 to 40 years age group, and some were less than 10, or some very few were more than 60 65 years. So when we analyze, these are the common symptoms: fever, cough, weakness, and you also see sometimes swelling in the neck, and very difficult to know whether if the swelling in the neck is because of HIV and TB unless you do an FNAC in such cases. So these are the clinical signs we found in tuberculosis patients with HIV. Common one that we coexisting lesions that we saw was with oral thrush and lymphadenopathy, skin lesions, and nail changes, genital ulcers. These were the main other problems that the patients had along with tuberculosis in HIV patients. So the coming to this slide shows, see the most common other infections that we have when you are treating HIV and TB. So we often see coexisting infections like PCP. That becomes a very difficult diagnostic problem because uh, when your patient will be started on anti-TB drugs and the patient will not be improving clinically. So sometimes, though rare, but we have seen many patients who have coexisting PCP along with tuberculosis. In our case, in our study, it was more than 9% of the patient had coexisting illness. So here we have to treat both PCP and ATT along with ATT. Maybe after the patient stabilizes, we need to start them on ART later on. And other problem that we had was more than 5% of the patient had hepatitis. As I've mentioned earlier, when you start the patient on anti-TB drugs, especially when the patients are in late stage, the chances of hepatitis is more. So always adjust the dose of anti-TB drugs, and the patient is having, if the patient weight is less, always monitor the LFT every 1 or 2 weeks to know whether the patient is developing any hepatitis. And only when the patients tolerate anti-TB drugs, then you start anti-TB drugs, maybe with efavirenz preferably, because the national program, because they include rifampicin, so we have no other option other than starting them on efavirenz-based antiretroviral drug in such patients. So these were the clinical manifestations: oral thrush, skin lesions, Ambaram tongue, which was a very common finding at that time, where you have bluish discoloration at the edges of the tongue. This patient also had axillary lymph node, and the cervical adenopathy is very common. Then you have skin and nail changes. So many patients, some have yellowish discoloration of sclera, and it's very difficult whether they really have jaundice or it's many patients have routine. I mean, we used to see very commonly yellowish sclera. So in that case, also you need to be a little cautious when starting anti-TB and antiretroviral drugs. So coming to the radiological pattern, in these cases, most of them we had post-primary and primary type of TB, and some patients with HIV and TB, they had normal X-rays. More than as much as 13% of the patients, they had normal X-ray. So when you are seeing HIV and TB patients, normal X-ray don't just rule out TB, because they might still be having TB, extrapulmonary TB or endobronchial TB. Wherein you just have to keep that in mind before starting them on antiretroviral drugs. And the miliary pattern is seen in 7% in our study at that time. So this is how the manifestations appear in the early stages of HIV. Because the patient's immunity is normal, the CD4 is more than 500 or so. So the patients will develop classical post-primary tuberculosis, wherein you have cavitary lesions and infiltrative lesions on the upper lobes. Whereas in the late stage, when the CD4 counts drops to very low, less than 100 or less than 150, there you see more of adenopathy type, mediastinal lymph node hilar adenopathy is very common, and infiltrates. The lung lesions are more seen on the lower lobes. So this is what we have observed during that study, as you can see from the data. So I wouldn't be going into the details of the figures, but as you can see, most of the cases are atypical for primary pulmonary tuberculosis, which is not typical for adult TB. It's commonly seen in children, but primary pulmonary TB is somehow seen in patients with late stage HIV, where they develop predominant lymph nodes. I mean, lymph nodes in hilar area. So in the post-primary tuberculosis, which is typical for adult TB, you will see classical upper lobe infiltration with or without cavitation. So these are the numbers and percentages, which I don't want to go into the details. I just wanted to highlight some of the important radiological pattern. Here you can see the patient had upper lobe, predominantly upper lobe cavity along with infiltrations, uh, classical post primary TB. Here you can see the primary TB, it's a clear cut lymph nodes enlarged hilar adenopathy. Otherwise, the X-ray looks quite normal, but here the hilar adenopathy was very prominent. So these are the kind of uh, uh, primary TB patients where they manifest only with lymph nodes. The X-ray appears normal, and the patient will not have any cough, fever in such cases. So, and this is a late stage TB, late stage of HIV, where you see the lower lobe lesions. Here you can see the cavity along with the consolidation in the lower lobes. And this again shows a very small lesions in the lower lobe. These are all confirmed cases of tuberculosis. We just analyzed the X-rays and tried to find out how the presentation was. Again, you can see the lower lobe tuberculosis consolidation. This patient had ameliorate tuberculosis, though it appears that lower lobes are not involved, but the patient had a severe disseminated tuberculosis miliary pattern. And as I've mentioned, some patients who have absolutely normal X-ray and patients still had TB. So these patients had sputum AFB positive. So always keep in mind that if the chest X-ray is normal, doesn't mean that he is not having tuberculosis. He still might be having endobronchial tuberculosis or extrapulmonary tuberculosis, wherein you just have to monitor the patient and keep in mind that they might, after starting ART, they might develop TB anytime. So these are some of the findings that this X-ray shows clear-cut hilar butterfly type of lesions in the hilar in the both hilar areas. This is a classical PCP pneumonia. This is how it appears. So when you have when the patient is having a young patient with a low CD4 count comes with you to with breathlessness, you should always think of having PCP. And if the patient is not having any, I mean, if there is that if there had been a cardiomegaly, and if the patient is an aged patient on hypertension or some other cardiac problem, you might think of pulmonary edema. But here it was simple PCP pneumonia because he responded very well with Bactrim. So with the conclusion was with the sputum conventional sputum smear and TB tuberculin sensitivity test, these tests are not they are not useful. I mean, tuberculin test especially doesn't provide any diagnostic help. So you have to be familiar with the clinical and radiological spectrum of tuberculosis, and also with the coexisting opportunistic infection. So we have to know the clinical picture, complete radiological and clinical picture of tuberculosis in such cases. So the diagnosis of TB has to be suspected in any HIV patient, irrespective of the type, site, and extent of the radiological lesions. And radiological worsening or appearance of new lesions in TB with HIV should not always attributed to poor therapeutic regimen, since it could be due to another coexisting pulmonary infections like PCP and bacterial pneumonia. So the early diagnosis and early treatment of tuberculosis in HIV patients is necessary to prevent the spread of TB infection. That's all for the presentation. Hello.
Thank you, doctor. So I have received a few questions from different places. So first question is from Guwahati from Dr. Jain. So doctor has asked that, doctor, I have switched few patients from efavirenz 600 based therapy to DTG because of CNS side effect, but the side effects are persistent. What to do?
Yeah, very, very common problem that we used to encounter when I was working in a ART center at Chest Hospital. We had only two regimens, either nevirapine or efavirenz. So these were the only two regimens available at that time. So we used to either give nevirapine or efavirenz. But efavirenz, patients develop a lot of dizziness. Some patients develop dreams also. They complain of vivid dreams occurring. So here, some regimens have come with 400 mg efavirenz. Here again, if you are not having tuberculosis, you can start them on 400 mg of efavirenz along with tenofovir and emtricitabine. But altogether, if your patient is not tolerating efavirenz, it's safe to switch to dolutegravir, which is a much safer option. Doesn't have any neurological, neuropsychological side effects like that you have with efavirenz. And dolutegravir, the only problem with that is some patients are find it very difficult to get the sleep, and these patients have to be counseled, and maybe it's better if the patient is affordable. If the patient is not tolerating efavirenz, you better shift them to dolutegravir based regimen if they can afford. And if the patient is already on TB drugs, if it is a regular rifampicin based regimen, then if the patient is on national DOTS program, then you have to continue efavirenz only. But if the patient is taking in a private setup in the where you have the the flexibility of shifting rifampicin to rifabutin, then you can start with dolutegravir also.
Yes, sir. Another doctor from Imphal, Dr. Mithun. One of my patient developed jaundice after putting DTG 100 mg based therapy with ATT. What is your opinion now?
So, the case which I have discussed, maybe you are also facing the same problem. So, in that case, maybe you are. I've already just mentioned when we see patients of these HIV patients, they have very low body weight. So, if the patient has very low body weight, you cannot start them on full dose. Sometimes full dose ATT, and if you are starting them on full dose ATT, just check their LFT every once in a week or twice in a week, because when the LFT goes above, when the enzymes when they are elevated, you have to stop some of the anti-TB drugs like paracetamide. You can stop to then you continue with isoniazid rifampicin. And even with isoniazid rifampicin, if the patient is not tolerating and if they are developing jaundice, then you have to completely stop ATT and start them on ethambutol and streptomycin along with levofloxacin. These are the recommended drugs that we need to take for tuberculosis. So you give ethambutol, streptomycin, and levofloxacin, and once the patient monitor them with LFT serial LFTs. If the patient is responding to your treatment and if the LFT comes back to normal, then try to reintroduce the anti-TB drugs slowly, one by one. Maybe you can start with isoniazid. Later on, you can add a rifampicin if you want. But again, because your patient was on dolutegravir, here you cannot start rifampicin. If you want to start rifampicin, you have to give 100 not 100 mg. 100 mg you have to, because the recommended dose was 50 mg dolutegravir. If you are already giving him on 100 mg dolutegravir, you can start them on rifampicin also. But if they are not tolerating anti-TB drugs, then you have to continue with only ethambutol, streptomycin, and levofloxacin for some time. Then maybe with the follow-up LFT, you can plan later about future TB drugs.
Another question from Hyderabad, Dr. Kumar from Hyderabad. The patient is using TLE 600 mg. Now he got TB. Shall I continue with TLE 600 mg or can I change to TLE mg 400 TLE 400 mg along with the TB medication as he is suffering from high dose of efavirenz?
Okay, so see, basically, when your patient is on anti-TB drugs, the actually previously the initial recommendation was 800 mg of efavirenz. From 800 efavirenz, they have brought down to 600 mg efavirenz. 600 mg efavirenz is good enough with anti-TB drugs. But when you are planning to shift to 400 mg, I wouldn't advise you to give 400 mg efavirenz with rifampicin, because that might the effect may not be good, because rifampicin also has interaction with efavirenz. It reduces the levels of efavirenz, though not that much as nevirapine, but it does reduce the doses of effectiveness of efavirenz. So in your case, it is better if you change the antiretroviral drug, because if the patient is not tolerating efavirenz, and you cannot continue to ask them to take efavirenz, because the side effects are really very troublesome with efavirenz.
Yeah, another question from Hyderabad, Dr. Reddy from Hyderabad. What is the role of darunavir and ritonavir combination in TB patient?
Like, see, when as I've already mentioned, you cannot give any PIs in patients who are taking rifampicin. So when you are giving any PI drugs, like maybe it atazanavir or lopinavir or darunavir, any PI drug, when you are giving along with rifampicin, the effectiveness will decrease to less than 40%. So no PI is recommended along with rifampicin. So in a national program, they would never give, they would never suggest. But if you are treating outside, so I would suggest, if they, because there are many other options available than darnavir, it's better to start with efavirenz or dolutegravir, along with, if you are planning to, if the patient has already failed dolutegravir, or if the patient has already failed efavirenz, atazanavir, then the third line we sometimes have to start the patient or darunavir. So only in such cases where there is documented evidence that the patient has already received other ART drugs and is not responding them well to those drugs, then you have the option of starting them on darunavir along with ritonavir. But in such cases, you cannot give rifampicin. You have to start with rifabutin only.
Yes, doctor. Another question from Imphal. One of the patient has gained 20 kg after putting on TAF, emtricitabine and dolutegravir. So what
Yeah.
to do now?
It's very common nowadays. Patients on dolutegravir, they gain weight very fast. Even I have seen many patients, of my patients, putting on so much weight. So in such patients, again, I have advised them to follow a strict dietary regimen and exercise. And because many patients, they are very reluctant to follow that advice, I have some most of the patients I have changed again from dolutegravir. I have switched to them to atazanavir or some other darunavir if they are affordable, because darunavir is little higher, costlier drug. So the only options that we have now is we can either shift to atazanavir based regimen if the patient has not already used any PI. So that is one option. If the patient is affordable, we can change it to darunavir based regimen. Other than that, if the, again there is another raltegravir which is safer option, but again raltegravir is almost twice the cost of dolutegravir, so the options are less. So these are the options that you have when the patient gains weight.
Sir, another question from Imphal. Doctor, many of the patients dropped therapy and came back after a few months due to ongoing challenges. What should be the next testing and treatment strategy?
Maybe everyone is facing the same problem here, even because of the COVID pandemic. Many of them have stopped coming, many of them have stopped taking antiretroviral drugs, and some of them have not going to ART centers. So here again, if the patient has uh, completely stopped, you can restart the same antiretroviral drug, but you have to monitor more closely now, because the patient might develop resistance to the drugs which he has used initially. So he has to check up his CD4 and viral load after 3 months of the antiretroviral regimen. So after 3 months of taking the antiretroviral regimen, if the viral load remains suppressed after 3 months, then he can as well continue the same old regimen that he was taking earlier. If suppose, on the other hand, if the after taking 3 months, if the viral load is not suppressed and if the patient is not improving clinically, then you might change it to a second line or even a third line drug.
Uh, Thank you, doctor, for answering all the questions. And now I would like to thank you and all the doctors who are attending this program. That especially for this, the World AIDS Awareness Month is going on, and we all from Ireland would like to thank all the doctors for healing your patients and treating them and showing them the hope for that they can live healthy life. So thank you, doctor, for your lecture.
Thank you. Thank you so much.